This program is brought to you by Emory University.
Good morning, everybody. Thank you for tuning in for our last journal club of this academic year. Our first presenter this morning is going to be Dr. Birju Rao. Birju is a fourth-year fellow in the clinical investigator track. He will be hopefully graduating here in a month and a half, and will be pursuing a fellowship in electrophysiology. But today he's going to talk to us first about the REDUCE AMI trial. So Birju, take it away.
Thanks, Dr. Williams. Thanks, everyone, for tuning in. As Dr. Williams mentioned, I'm going to be producing the REDUCE AMI trial, which was presented at Georgia ACC, or at the ACC that was in Georgia this year, and simultaneously published in the New England Journal. I have some disclosures not relevant to this talk. Just quickly, our learning objectives will be to first talk a little bit about controversy regarding beta blocker use in acute myocardial infarction. Then we'll be talking about the results of the REDUCE AMI trial, and then finally, future directions and unanswered questions regarding beta blockers in the acute MI population. So just some background. Obviously, beta blockers are a foundational therapy in patients with heart failure, and there is sort of a lot of good evidence for them in the acute MI population, though all this data, or most of this data, comes from well-done, robust clinical trials that were done in the pre-high sensitivity troponin era, and many of those trials were conducted in the era of lytics, and not in the era that we sort of currently practice in, where you have, second, third generation drug-coated stents, dured balloon time, those sorts of things. But in the prior trials, there has been a very significant 20% risk reduction in acute MI when we're using beta blockers in this population. There has been, given some of this data was old over the years, there has been question of how relevant this data is, and how relevant is the use of beta blockers in the modern era, where most patients who come in with MIs get revascularized pretty quickly with modern revascularization techniques. Shripal Bangalore's group in New York has done quite a bit of work in this space, looking at mostly observational data in patients with coronary disease. They haven't found any significant benefit in those studies. However, guidelines still recommend folks get routine beta blockers after acute MI. So, and this is another one of Dr. Bangalore's meta-analyses that he did, looking at the benefit of beta blocker across 60 clinical trials. As you can see here, the outcome of interest is mortality. To the left, we have favors beta blocker. To the right, we have favors control, and everything sort of falls very close to the middle. So this is sort of what sparked interest and set the stage for this trial that we're gonna talk about. But before that, I want to make sure that we talk about what do guidelines tell us, because this is sort of what will inform a good amount of clinical practice, and certainly when we're talking to fellows, this is what's discussed in board exams, etc. So European guidelines, beta blockers are recommended with a class 1A indication in ACS patients who have an abnormal EF. And then with a 2A in all ACS patients, regardless of LVEF. US guidelines, beta blockers, they sort of break it down between, or further sort of categorize ACS into STEMI, which is a class 1B. And then with non-STEMIs, there is a 1C recommendation for folks who have abnormal LVEFs, and then again 2A, and folks and STEMIs with normal EFs. So this, again, set the stage for the REDUCE AMI trial, which tested beta blocker efficacy in patients who had an acute MI but a normal left ventricular ejection fraction. So generally these tended to be, for the most part, not big anterior MIs, not big anterior STEMIs. And what we compared were beta blockers, metoprolol and bisoprolol, against just a control of no beta blocker treatment. The design of the study, it was a randomized control trial. It was a European trial that was multi-center. We'll talk a little bit more about this, but it was a registry-based open label parallel trial. It was a very well done, pragmatic trial that was sort of embedded, mostly done in the Danish population and embedded into their usual care of how they track patients given they have a nationalized health system. So inclusion criteria was angiographically obstructive coronary disease and a normal LVEF on surface echo. Exclusion criteria were if they had any indication or other contraindication for beta blocker. So if they had an abnormal EF and they had an indication for beta blocker, they would have been excluded. Or if they, for example, weren't able to tolerate beta blocker therapy for whatever reason, or if they had VT and they needed beta blockers for that, obviously all those patients would have been excluded. So when we're looking sort of at the PICO type of sort of schematic for assessing clinical trials, the patients that this would be relevant to is acute MI status post revascularization. Again, I didn't put this here, but they have a normal EF. The intervention is metoprolol 100 milligrams or bisoprolol 5. Control was a placebo. And the outcome of interest here primarily was a composite of death and MI. So this is the Sweetheart Registry, which is, I talked about this trial had a sort of unique design, registry-based open label parallel group design. So the Swedes have a really interesting way of monitoring their healthcare system. So they have a nationalized health system, and they have everyone falls into this giant registry where they look at health outcomes, and this is sort of embedded into usual cares, which is really unique and allows them to do really, really robust research without using millions and millions of dollars to get people enrolled in clinical trials, et cetera. And again, a nationalized health system allows easy tracking for hard outcomes like MI or death, because even if you present to some outside hospital, you're still within the nationalized health system. That being said, if you leave the country, obviously you would fall out of that health system. And then again, this database that they used as part of this trial, and again, just to be clear, this Sweetheart Registry existed far before this trial. Part of this trial, and has a robust data on atrial fibrillation, heart failure, all sorts of things, and then ICD codes that would be used as part of normal routine clinical care were embedded into this database. The statistical analysis that was done here, so power calculations, they assumed a 7.2% per year event rate in the no beta blocker group. That was based on sort of the old data from the sort of the pre-PCI therapy era. The minimal, the MID is the minimal important, least important difference that you want to sort of try to detect is an event rate of 1.2%. They actually adjusted this in the middle of the trial to 0.09 or 0.9% because the event rate was much lower than this event rate, which we'll talk about a little later. Also, at a 80% power, 5% significance level, the N that was required was about 5,000 patients. And the analysis, nothing fancy, the usual stuff, an intentional tree analysis, comparing outcomes. They used Cox unadjusted proportional hazards, and then they did proportional hazards by means of visual inspection with analyses, censoring data after different cutoff points. They also did do a sensitivity analysis using age, diabetes, and prior MI to see if there was any sort of signal of a specific patient population in which beta blockers would have been helpful, and older patients, younger patients, folks who had diabetes, folks who had prior MI, et cetera. So the results, trial started enrolling in September 2017, ended enrolling in May of 2023. captured a little over 5,000 patients, 5,020 who underwent randomization. And then most of these, again, were in Sweden. I know I mentioned it was a multinational trial, but the vast majority, most part, this is a Swedish trial. There were some people in Estonia and about 200 patients that were enrolled in New Zealand. Follow-up was fairly robust at 3.5 year, 3.5 years. There was about 85% completed follow-up. At the end, the group that was sort of allotted to be taking beta blockers, 81.9% were still taking them at the end in the treatment group. And then 14.3%, this is kind of interesting, were taking beta blockers in the control group. So a little bit of crossover. Talk about that in the sort of discussions and interpretation of the study. Again, after 3.5 years of follow-up, the primary endpoint, death or MIs, combined endpoint, occurred 7.9% in the beta blocker population and then 8.3% in the control group. The confidence interval crossed 1 here, obviously not statistically significant. No statistical significant difference between the two groups. Here's sort of the table 1, where we're trying to sort of see what types of patients they had. Again, median age, 65 years old. They had a predominantly male group, where only like about 22% of patients in this trial were females. We talked about that they're mostly all from Sweden. In terms of risk factors, which is when we think about how applicable is this trial to the patients we take care of, not that much diabetes, not that much smoking, a lot of hypertension. So probably a little healthier patient population than what we see here in Georgia. And again, both groups, you can see fairly healthy group. They didn't have a lot of cardiac comorbidities. Very few people had prior MIs, had prior open heart surgery or stroke, heart failure, etc. And the vast majority of these patients, again, this was an acute MI trial, so everyone had chest pain as their main symptom for the most part. Interestingly, there was about 35% of people in the groups had ST segment elevation at actual STEMI. And then in terms of their coronary anatomy, vast majority had one vessel disease. There were some who had two vessels, very few who had left main or triple vessel disease. Again, 95% of people got PCI. There were a couple percent of people who ended up getting CABG. This is sort of interesting too when you think about it, what a good job the Swedes do in terms of getting people on good GDMT or good OMT after post-MI. Virtually everyone, like 97, 96% people were on aspirin, P2Y12. Obviously, the beta blocker group, they were on beta blocker. And then, a good number of patients were also on ACE or ARB, statin, 99%. So a lot of these people, I think the sort of take home from this slide is that relatively healthy population who were already placed on good medical therapy, and very few had multivessel disease. So here's the sort of primary endpoints that I had chatted about earlier, but essentially when we're looking at death between both groups, there was no major difference. When we're looking at some of these secondary endpoints, death from any cause, no significant difference. MI, hospitalizations, et cetera, everything was sort of no significant difference, no major safety differences as well. Here's the sort of Kaplan-Meier curves if you're a visual person, but interestingly, they sort of crossed in the middle and then diverged a little bit as the years went on, but then again came back together. This is primary endpoint. This is death from any cause. So, I think as we're talking about the discussion, interpretation of this study, what's really interesting is that, a vast majority of patients were treated with the full armamentarium of modern post-MI care. Virtually most patients got PCI. Virtually everyone was on DAPT, statin. and greater than 80% got an ACE or ARB. Few of these treatments existed back in the 80s when a lot of the beta blocker trials, post-MI beta blocker trials were done. Again, I think this is sort of interesting, is that adrenergic blockade with beta blockers in the pre-PCI era probably reduced mortality by a reduction of, ventricular arrhythmias and wall stress-related complications that were seen in the lytic era or the pre-PCI era. Again, these things are relatively rare in the PCI era, particularly in patients who have normal EFs. One sort of criticism that I thought of was that there were low rates of bradycardia in the beta blocker group, indicating that the medicines may not have been maximized. You try to want to, with beta blockers and everything, you want to try to get to the point where patients are getting symptomatic and being able to back off a little bit then. So if your patients are not reaching points where they're getting side effects or bradycardia, then there may be some unrealized benefit there. And again, I mentioned this, there was non-trivial rates of crossover, 18 and 14% respectively between the treatment and control arms. So it's important to note. So, there was John Mandrola who writes a blog on Medscape, This Week in Cardiology. It's like widely followed. He posted that, is this a medical reversal? Medical reversal, interestingly, are things that we are taught are beneficial, and then new data comes out and then it actually shows that they're either not beneficial or harmful. This happens quite a lot. I think this is sort of why we do these journal clubs and why we sort of continue to not be bogged down by dogma and asking good questions. This is a study sort of looking at the different types of medical reversals that were done by specialty. So I think one other thing I wanted to mention is a note about pragmatic trials. So the Scandinavian health system, I chatted about this earlier, is that they're really able to embed clinical trials into routine medical care, which allows, there's a couple of things you can think of for that. It allows for better external validation because this is sort of filtered into routine healthcare. There's less Hawthorne effect. There's less concerns for, whether this is externally applicable as people in the trial being treated differently. Again, this may be more prone to bias, again, because it's not a sort of a contrived environment. This is just routine clinical care. And importantly, I think something that I care a lot about is cost. This is much less costly to be done. I think if I remember correctly, it was about $500 million. What was the big headline for the ischemia trial, which reiterated results of courage, et cetera. So the important things, I think this is a cool trial, well done. There are some clear limitations regarding crossover, and obviously it's embedded into routine clinical care, so there's bias there. Needs to be interpreted with results. I don't know if I feel as strongly as Dr. Mandrola did about this being a medical reversal. All these patients were relatively healthy and had normal EFs. I think in terms of what this tells me is that in patients who were otherwise really healthy, who are on good medical therapy, who got PCI relatively quickly and have a normal EF, we don't necessarily need to be as aggressive with beta blockers, but curious to see what the rest of the audience thinks. I think I've left a couple minutes for questions. Thank you.
Thanks, Birju. You said it right. So the EF cutoff was 50. They had to be 50 or above, or if they were 50, they were excluded.
It was at 50, they were excluded.
Okay, so they hit 50, they were excluded. Yeah. I mean, you just sort of took the words a little bit out of my mouth with your last sentence there. It's something that it's good to have good data on, but it's not something that's shocking that, a patient, like you said, a relatively healthy cohort with relatively preserved ejection fraction after MI, the beta blockers aren't gonna, move the needle a whole bunch for them. But
I think this is in terms of one patient population, this makes us feel a little better, is like otherwise younger or healthy people who have side effects from beta blockers, who are active and feel terrible and have fatigue. We
Yeah.
shouldn't necessarily feel as bad for stopping it, for quality of life, because they may not be getting necessarily a tremendous bang for their buck from a mortality standpoint, which is a nice feeling, I guess.
Other questions, comments from the audience?
Stan Sherman. Are they continuing the trial? In other words, I think you said it was like 3.5 years, and that's not a whole lot of time in somebody's lifetime of being on beta blockers. And since they didn't have much damage done, I guess a lot of these were non-ST elevation as opposed to ST elevation MIs, where you do expect damage and LV dysfunction. So it's certainly an interesting trial, but I guess to change what I do, I want to know that patients that I've followed for 10 years, don't need beta blockers.
Yeah, that's a fair point, Dr. Sherman. I suspect that they will. I mean, like I said, the nice part about this trial is embedded into their routine health, the routine healthcare. So it becomes pretty easy for them to report, 5-year data, 10-year data, which I suspect that they will do. But it's a good point. Thank you.
Okay, very good. Thanks, Birju. Appreciate it. Our second speaker this morning is Dr. Graham Smith, third-year fellow in our clinical track, also hopefully graduating here in a few weeks. Dr. Smith will be moving on to Charleston, South Carolina, join the Medical University of South Carolina and later this summer. And he has a study without a fancy, abbreviation title. So I'll just let him take it away.
All right. Thanks, Dr. Williams. Appreciate you guys being here to listen. Great talk, Birju. I was actually going to do the same one, but yeah, I think you did a better job. So good job, man. So this trial that I chose to do is called an Inclisiran first strategy versus usual care in patients with atherosclerotic cardiovascular disease. Some objectives that we'll go through. First off, what is Inclisiran? How does it work? We'll review the guidelines regarding lipid goals. We'll also describe the trial, of course, look at its results and some of the surprising findings that I thought were not very expected, and then also discuss where this therapy can fit into our current lipid lowering therapy strategies or lack thereof. So let's get into it. So first off, kind of what is this new drug? Inclisiran, or the brand name Leqvio. You might have heard of it or seen some of the commercials on TV. It was approved in the U.S. December of 2021, so pretty new. Drug approved about a year before that in Europe. So it is a first-in-class small interfering RNA drug. So it inhibits hepatic proprotein convertase subtilisin kexin type 9, or more commonly known as PCSK9 production. And this increases hepatic expression of LDL receptors on the surface of hepatocytes, and then that'll in turn lead to increased LDL clearance from the bloodstream. Just kind of to review PCSK9, because I need to look at this again just to kind of refresh my memory of exactly kind of what its effects are, and kind of LDL regulation. So just to go through that briefly. So it's a protein in liver cells that leads to degradation of LDL receptors on the surface of those cells. PCSK9 will actually bind to the LDL receptors and promote their destruction in the lysosomes inside of the cells. This will reduce the number of cell receptors on the surface of these cells, thereby reducing the amount of LDL receptors, LDL from the serum. So inhibiting PCSK9 can increase the expression of these receptors on the surface of these cells and lower those LDL serum levels, like I said. Here is a schematic just to kind of really get that into your head. So here we have in green the PCSK9 molecules, and you see it binding to the blue LDL receptors here. When it binds these receptors, it'll actually facilitate the bringing in of these receptors inside the cell, and they end up in the lysosome getting degraded. So you might have, I guess we're probably a little more familiar with the little older drugs now, the monoclonal antibodies that inhibit PCSK9, or Repatha is one of the trade names of Atherosclerotic. So how do those work? Just so we can compare the two mechanisms of action. So these monoclonal antibodies will bind to the PCSK9 and actually prevent the PCSK9 from binding to those receptors. Therefore, there's going to be less degradation of these receptors, and there'll be more expression of them on the surface of the cell, so that these receptors can clear more LDL from the bloodstream. So how does this newer first-in-class medication Inclisiran work? So it's a little different. It's actually a small RNA molecule that they engineered to be attached to a sugar molecule, which is this GNAC tail here, to help facilitate it to get inside the hepatocyte. Once inside the hepatocyte, the small RNA molecule binds to what's called an RNA-induced silencing complex. And then once that's bound, it'll actually it'll lead to downstream to the degradation of PCSK9 mRNA. So you actually get less translation of the actual protein itself. So you get less PCSK9 in the cell, which then downstream, of course, like we discussed, will lead to more LDL receptor expression on the surface of the cell, and then more uptake of LDL from the serum, leading to lower LDL levels in our patients. Just a few more kind of details about this drug. So what was it approved for by the FDA? It was approved as an adjunct to diet and maximally tolerated statin therapy for the treatment of adults with FH, clinical atherosclerotic cardiovascular disease, and primary hypercholesterolemia who require additional lowering of LDL despite maximally tolerated statin therapy and lifestyle changes. How is it administered? So as opposed to the PCSK9 inhibitors, it's actually a sub-Q injection that the healthcare provider has to give in the office. The dose is 284 milligrams. There's a second dose at 3 months. And then after the 3 months, you just have it every 6 months. So kind of every 6-month office visit with your provider. This is, when compared to Repatha or some of the other, PCSK9 inhibitors, those are injections every 2 weeks that can be done at home or monthly. In terms of effectiveness, they do have a lot of data on this. It has a good mean reduction in LDL, pretty impressive, about 50%, which is similar to a little bit older PCSK9 inhibitors. But there's no robust data yet for Inclisiran in terms of what it actually means for cardiovascular outcomes and things like that. So it's still kind of earlier on in terms of its data, and that's for sure. So talking about cost, which is, of course, like front and center when it comes to these newer therapies. Couldn't find much, honestly, which I don't know if it's by design, but kind of the list price of Inclisiran is $6,500 per year, or about $3,250 per dose. And again, you'll once you're on your maintenance regimen, you'll have 2 doses a year. Comparing that to Repatha, it has a list price of about $561 per month, which translates to $6,732 per year. So kind of similar list prices. For what it's worth, this was, I was trying to find some good data on the cost, the actual out-of-pocket cost for patients with who are taking Repatha. And full disclosure, I ended up having just to get this from their website, so take it with a grain of salt. But according to this large healthcare consulting firm that's called IQVIA, 71% of patients on Repatha who have Medicare, the cost was actually $49 or less per month. And then 82% of commercial, people with commercial insurance ended up paying $49 or less per month. This doesn't take into account the effort it takes to actually get people on the drugs and get them approved and pre-authorizations and all that, of course. But, I was a little surprised if this data is accurate. I thought patients would probably be paying more for this, even with coverage. So let's just kind of get a good understanding of the most recent guidelines, kind of remind us of what they say. The last big guideline regarding cholesterol management was in 2018. And a 1A recommendation, we're all pretty familiar with this, in patients who are 75 years of age or younger with clinical ASCVD. They should be on high intensity statin therapy and should be trying to get below 50% or 50% reduction in what they started at with their LDL levels. Even back in 2018, we were already mentioning the PCSK9 inhibitor therapy and how this would kind of get incorporated into lipid lowering therapy. They mentioned it kind of, it can be considered if people are on maximally tolerated statin and other things like Zetia. But they were very aware of the cost back then. The cost was almost way more prohibitive back in 2018. So they hedged quite a bit, understandably, about that with the guidelines. Just kind of continuing one more recommendation from those 2018 guidelines. This is basically, I'm just trying to drive home the point that we know patients do better with lower LDLs and pretty drastic lowering of LDL, so lower than 70, which is difficult to achieve in a lot of our patients. But this has been known for a while and is supported by a lot of data that we need to get patients who have clinical ASCVD to get below 70 LDL serum or get their non-HDL cholesterol lower than 100. And again, they mentioned that it is reasonable even back then to add on a PCSK9 inhibitor at that point. Last kind of guideline thing, I promise, this is just the most recent update from kind of a large body that we have, is from 2022. And I apologize, this schematic kind of was a little, I think I was a little ambitious for trying to put this on one slide, but just bear with me. This was from the 2022 ACC expert consensus document that they released. And I think this just, I think it's just kind of helpful when I'm about to talk about the trial to kind of see what the big bodies are trying to get clinicians to do in regards to statin therapy and if we're actually doing that or not. So again, they emphasize the greater than 50% reduction from your baseline LDL cholesterol. And then here, which is a little more updated than the guidelines from before, you can see if you're not able to achieve that with statin therapy, the options to add additional non-statin therapy here, they go, first choice would be ezetimibe. Second choice here, they mention PCSK9 inhibitors, and then third, may consider bempedoic acid or inclisiran. So this is kind of where inclisiran makes its debut in some of these larger societal documents and guidelines. So where does this trial fit in? What questions it can help answer? So despite all the data showing that lowering of LDL cholesterol improves outcomes in our patients and guidelines recommending that for years, unfortunately, real world studies have consistently shown that up to 80% of patients fail to achieve these LDL goals. So that's kind of where this trial comes back in. They were trying to see if they can get these LDL goals down using this Inclisiran first strategy. And so kind of what does that mean? To describe, just let you know what the methods were. It was a prospective randomized trial based in the US, multi-center parallel group, and it was open label. And it was trying to see, the difference mainly in LDL levels in patients who were already on maximally tolerated statin therapy, but still had LDL above 70. And if they kind of went ahead and gave, randomized patients to receive Inclisiran, or if they continued with their usual care and kind of looking at their levels over time. In terms of patient selection, they wanted to include patients over 18 with a history of ACS VD, which includes coronary artery disease, cerebral vascular disease, peripheral artery disease. To be included, they also had to have LDL levels of equal to or greater than 70, or non-HDL cholesterol greater than 100, and fasting triglycerides less than 500. And so research sites, they were trying to get people who were on maximally tolerated statin therapy as determined by the investigator with no immediate plans to adjust their lipid-lowering therapy. And statin intolerant patients were eligible if they had tried, if they had documented side effects on 2 or more different statins, including one at the lowest standard dose. So here is, looking at the study design, kind of a good schematic here. So they were randomized at day 0, and then the group who got randomized to Inclisiran first got their first dose of Inclisiran on day 0, and then like I mentioned how it's administered then on day 90, 3 months after, and then you go to kind of every 6 months after that. So at visit 5, they got their 3rd dose of Inclisiran. And then, people there ended up being 225 patients in each arm of the study. Here's a flow chart of kind of the patient disposition in the trial. So like I mentioned, there ended up being about 225 patients in each arm. Not too much, not too many patients were lost to follow-up, with the majority of patients completing the trial in both study arms. Here is our favorite chart about patient demographics in the study. I think, it's pretty reflective of patients we see at Emory. Average age was 60, late 60s, 30% female, about 12-13% African American. There was a good variation in income level with about 40% in both groups having less than 50,000 annual income. And then you can also see there was about a fourth of the patients in each arm had a history of statin intolerance, as you can see there. This is the same table, just kind of more baseline data. So the average LDL in both arms was about 97. And then below that, you can see the kind of characteristics of what lipid therapy these patients were on at baseline. And interestingly, only 9 out of 10 or 90% of the patients were on any lipid lowering therapy, despite them saying, they wanted patients who were ideally like already on maximally tolerated medicine if they were able. So you have 90% on statin. Most people, the vast majority, were just on statin monotherapy. Very few, which was kind of surprising to me, were on statin and ezetimibe. Especially given the fact that these patients, according to the guidelines, hadn't met that lower than 70 LDL goal. Only one. Very few patients were on combination lipid lowering therapy, which we'll talk about a little bit later. So for endpoints, what were they looking at? The primary endpoints, percentage change in LDL cholesterol from baseline to day 330. And then they also looked at discontinuation of statin therapy or no statin use greater than 30 days before the end of the study visit. Other endpoints, so they looked at a lot of different other things, percentage change in LDL from baseline to each post-baseline visit, and then the proportion of patients meeting those pre-specified goals, like we mentioned, they were kind of driven by the guidelines, greater than 50% reduction in LDL from baseline, less than 100 or that was for non-HDL, and there's less than 70 for LDL. They also looked at changes kind of in their lipid lowering therapy throughout the course of the trial. Again, like patients in the usual care arm, the providers were allowed to, they were encouraged to advance their therapy as they would, if they were not in the trial, just based on guidelines. They weren't, told to just keep them on what they were on at the beginning of the trial. So usual care didn't mean just keeping them on, like those 90% of the patients who were just on statin monotherapy. It didn't include that. They were able to advance their therapy as the clinician saw fit. And then they got some overall safety and tolerability data of in the drug arm. So let's kind of dive into the results. There's a lot of different charts here. I apologize, but I think they're all pretty useful. This is the percent difference in LDL divided between the two arms. As you can see, not unexpectedly, this, in the Inclisiran arm, pretty impressive LDL reduction compared to the usual care. Even starting at the 90-day visit, you already saw at least 57% reduction in their LDL levels. And these levels stayed low throughout the course of the trial. Interesting that you get the kind of, you're almost looking at the maximum benefit at 90 days. And then with the subsequent dosage, you're kind of just maintaining that benefit. You don't get, even further reduction, it seems. This is the absolute change in LDL as opposed to percentage, kind of showing the same thing. The other primary endpoint or statin discontinuation that they tracked, there was actually more statin discontinuation in the usual care arm, 16% compared to 6% in the Inclisiran first arm. Tracking some of the secondary endpoints, this is the percentage of patients achieving LDL guideline goal of less than 70 in patients with ACS-VD. You can see the drastic difference between the patients achieving that goal in the Inclisiran arm versus the usual care, about 80% in the Inclisiran arm compared to just 22% at the end of the trial. And then even further, we like lower LDL. So this is showing the figure B is less than 55 milligrams per deciliter for LDL. And so a fair amount achieved that as well in Inclisiran. Just another way they really want to just drive home the fact that they lowered LDL. Here is what's called a spaghetti plot. So you can see in the blue with Inclisiran, many more patients achieved that goal of less than 70. Here are some of the other biomarkers that they were tracking. It's just showing that people in the drug arm also had significant decreases in these other types of cholesterol, triglycerides, and things like that. So it's not just lowering LDL. Here is, they tracked the kind of what encompassed each patient's lipid lowering therapy. And you can see at baseline, that is the lighter colors here. And then at at the end of the study, day 330 is the more bold lines. So interestingly, in the usual care, like I said, they were allowed to advance the therapy as the clinician saw fit. They weren't, told to just kind of stay with the status quo. So some of them were, you can see statin plus Zetia here. About, only 1.8% of those patients in the usual arm at baseline were on statin plus Zetia. At the end of the trial, 10%. So they 9% more of patients had Zetia added despite their LDL still being above goal, which I thought was very surprising. And here's just a breakdown of the statin therapy into intensity of the different groups. You can see, that 90% roughly in both groups were on high intensity statin therapy at the beginning of the trial. They did track major adverse cardiovascular events, or MACE. The event rate was very low, as would be expected in a trial that's like less than a year with follow-up. Only about 16 events occurred in either, as a total event rate. So there's actually a few more events in the Inclisiran first group, but it's tough to draw any, serious conclusions about that with the event rate being so low. They also tracked safety events and things like that, and comparing the two arms. There were, more of these treatment emergent serious adverse events in the Inclisiran group. That even included things as like injection site reactions, things like that. But the authors concluded in the end, when they looked at this, that there was no real significant like safety concerns with the drug. Here, I just thought it was important. This is a continuation of the same table. This far left column, the numeric values are the Inclisiran group, and in the middle you see the usual care arm. I just thought it was good to know that, with these different biomarkers that we check, like liver function studies and creatinine and creatinine kinase, that there was no difference between the two arms of the study. Here's their kind of summary illustration to kind of drive home the main points of the study that I thought was useful. Big points are that Inclisiran, as expected, dropped people's LDL with many more patients achieving that goal of less than 70 in the Inclisiran first group. That was 80, almost 82% compared to just 22% in the usual care arm by the end of the study. And interestingly, there was less statin discontinuation in the Inclisiran first group than it was in the usual care group. And in the Inclisiran first arm, is important to note that they were able to continue their current statin therapy as the clinician wanted. They didn't have to stop their other statin lowering therapy in the Inclisiran first arm. And you can see the safety data as well, with a majority of these treatment related adverse events being injection site reactions. So we can, just kind of overall take home points. This drug does decrease LDL, and given the issues that we have with getting our patients under guideline directed LDL goals, this is a potential solution, although it definitely has caveats associated with it with this drug. I thought kind of the most interesting takeaway for me in this study was that our usual care, or whatever that was referred to in this study, that there are a lot of issues with that. Very few patients in the usual care arm had statin therapy increased, even despite being like in a clinical trial where they were encouraged to follow guidelines and kind of, even potentially be more aggressive than they would have without being observed in a clinical trial with people's lipid lowering therapy. Only 12.6 patients in the usual care arm received combination lipid lowering therapy by the end of the trial. And again, only 22% achieved that LDL cholesterol goal of less than 70 in the usual care arm. As the authors mentioned in their discussion, that these results unfortunately align with a lot of the registry data that we have about lack of being able to attain the LDL cholesterol goals that the guidelines have set out. And data has shown about 20% of these patients, only 20% achieve these goals. A big driver that they mentioned in the paper, which I agree with, is clinical inertia, but we also have medication adherence issues and side effects, especially related to statins and statin intolerance that I think are driving this lack of attainment of this goal. The trial's limitations. So, they compared it to what they called usual care, which is definitely not, like, as we saw with the data, it wasn't really like best practice, or they didn't really follow guidelines. So it would be interesting to see if they could look at, to have the comparison arm be an arm that actually is like more aggressive with adding on non-statin lipid lowering therapies like Zetia, things like that, and being more aggressive than the usual arm in this case was. It wasn't, well, I don't know if it was like the best comparison group. Cost effectiveness was not evaluated, as like, usually with that type of data, you need way more outcomes data to see if the drug is actually worth the cost. It wasn't open label design, so patients knew what they were getting, if they were getting the study drug or not, and that could have led to patients dropping out of the usual care arm or dropping out of the study if they don't get the newer drug. Also, when people know they're being observed, or the Hawthorne effect, it can affect things like medication adherence and statin discontinuation. So that can also differ from real world experience, because people know they're being observed. And also, it was funded by industry, which is not surprising, because they need, they're trying to bring their drug to market, and we don't have great other sources of funding for this kind of stuff for new drugs. In terms of future directions, I think this is a promising drug. It needs, it doesn't have any real robust cardiovascular outcomes data like the PCSK9 inhibitors do. They actually have some data showing that those do improve cardiovascular outcomes. I think going forward, it would be interesting to see a randomized, blinded trial of Inclisiran, this newer drug, versus the PCSK9 inhibitors in the appropriate patient population. And kind of the last take-home point, this was, I think, kind of the most surprising point for me, that we need to better address and understand clinical inertia and other drivers of the drastic underutilization of currently available and more feasible options to get people's LDL levels at goal. Like, why was the use of stuff like Zetia so low, and even intensifying statin therapy was probably looked like it was underutilized as well. So be interested to get y'all's thoughts on that as well. But thank you for listening. Appreciate it.
Thank you, Graham. Yeah, very good summary. It obviously seems to be quite effective and well tolerated. But the big thing is cost, right? That's sort of the elephant in the room, and was probably the big limiting factor with PCSK9 inhibitors when they came out, and their initial that was the main barrier to widespread use when they first came out. So that, I guess they didn't really address it much in the paper, or.
Yeah, well, all of these, the vast majority of the patients were like insured, I think.
Yeah.
So.
But did they talk like what? I mean, they probably didn't want to get into like what the anticipated cost of this drug was, relative to PCSK9 inhibitors, et cetera.
Oh no, yeah, they didn't get into all that. Yeah.
Questions, comments from the group?
Hey, Graham, this is Will. Thank you for that excellent presentation. I just had a question or a thought. Given the clinical inertia with some of this lipid lowering therapy, do you think there's going to be a time where we could use PCSK9 inhibitors, whether it's the monoclonal antibody or the siRNA, as part of standard of care for all patients with acute myocardial infarctions who come to the hospital? That way we address this earlier on and hopefully get lipid lowering early rather than later in clinic. What are your thoughts?
Thanks, Will. Yeah, that's a good question. I think like more and more, I think these sub-Q therapies will kind of be implemented earlier on in patients' treatment pathways, but I think we have so much room to go already on the more easily available things we have, like increasing their intensity of the statin therapy and also adding things like Zetia. And then, now with bempedoic acid as well, if they have, because so many of the patients do have real side effects with statins, that we can use bempedoic acid plus Zetia. There's like, a combo pill with that. So I think we first need to kind of use what we have that's cheaper and shown to be effective. The Improve It trial that looked at Zetia plus simvastatin had really impressive LDL lowering. I think it was like, with high intensity statins with Zetia was like 40% lower LDL, which is, approaching sometimes what these injectable sub-Q drugs get. So I think maybe if the cost comes down, you could see more of these injectables being implemented earlier on. But I think the big takeaway for me was like that we need to kind of get much better at using what we already have and what's easier to get and a lot cheaper.
Graham, I've got a question. Patient asks you, you're going to give me a medicine that's going to stay in my body for 6 months. How do you know that that's safe to do? And also, would there be any concerns in patients who have complex disease states, liver disease, that sort of thing? I guess these patients weren't included in these trials. Is there any concern that we're putting a drug in the body for 6 months?
Yeah, I mean, that's a good question. I think that's why, the way these drugs come to market, they do, safety data over and over again. Of course, there's no super long-term safety data because the drug has only been approved in the US since, 2021. But I think you can, patients that want to hear about trials and data, some don't, you can at least show them that there's been pretty large scale trials, albeit short term, that show no significant, increase in adverse events that will like actually affect their lives usually. But yeah, I mean, we only know about it for as long as we've known about it, and there could be, things that we're not anticipating down the road that we see with these drugs long term. But usually they're, as of now, they're being used in relatively pretty healthy patients. So I would be hesitant to push these on sicker patients at this point. Yeah.
Quick comment from Dr. McGorris. Compliance may be improved with patients if they, I guess, yeah, if the medication could be delivered at their clinic. Good thought.
Stan Sherman, where are they in the approval process right now in terms of who is Inclisiran approved for right now, or is everybody in the study?
Yeah, I'll let me show. There's one of my earlier slides that has the FDA approved indications up here. So this is what it's been approved for as of now. So as adjunct to people with the main use is like ACSVD patients who require additional lowering of their therapy. So it's kind of a similar indication to like other add-on therapies like Zetia. It's pretty wide indication, but I imagine it's not, it could probably be different. I haven't had any personal experience trying to get one of these like approved. I've done PCSK9 inhibitors a couple times, but not I haven't tried to prescribe this drug.
This is Neil Dicker. Just one quick point that I think is important. To me, the most interesting challenge with this is not is not really as much the compliance piece as much as what are the outcomes that are actually necessary when you have a class of drugs like this that are a new drug that comes out that works similarly but not identically to a PCSK9. You mentioned that we don't have sort of long-term outcome data, whereas we do have that with PCSK9. The challenge is that's not a trivial kind of data to acquire in a condition where the outcomes are long-term, takes huge numbers of people. I'd be interested in your thoughts on whether, you know, the short-term outcomes related to lipid lowering in this case as a sort of surrogate outcome, are they sufficient, or do you have to wait the years and years it takes to actually get longer-term outcomes when a drug sort of works similarly but not identically? It's a really interesting practical challenge.
Yeah, I agree, Dr. Dickert. I think you know, they do lower LDL at a similar rate than the PCSK9 inhibitors, so you could infer from that you're going to have similar outcomes data. But you know, can you say for sure? I don't know, but I know those trials take a long time and are very expensive, and you have to have you know, they got to be powered with a number with enough events occurring and all this stuff. And I know there's even controversy now with what do we, you know, count as like MACE or a major adverse cardiac event, like if non-fatal MI is actually significant or not. Dr. McDaniel's talked to me about that at Grady some. So
All right, well, thank you. Yeah, particularly in a primary prevention trial, which is even, you know, more difficult than a, you know, secondary. Usually, I guess they would start with a secondary prevention trial and move on to primary. But thank you to Graham and Birju for presenting today. Fantastic job to both of them, and everybody have a great day.
The preceding program is copyrighted by Emory University.